I'm really proud to work in the NHS, and that pride, I think, is always amplified for me when I come to sessions like this, when we talk about innovation and education. But just right at this moment in time, I often hear people say to me, it's the worst of times. We were certainly listening to the news yesterday about the CQC report. It did make me feel very proud about the care that was happening in some places across the NHS. But if people believe it's the worst of times, how are we going to achieve the ambitions that we've got for our NHS, for our healthcare system in this country? My job here today is to talk about hospitals, GPs, and community services type of environment, the environment in which we all work, and to talk about innovation from a point of view that's not the sexy new stuff. It's about stuff that's happening today, day in, day out, in different hospitals, communities, and GP practices. And why is it we're not spreading it into every hospital, GP practice, and community service? We know that we have some of the best outcomes in Europe, but we also know we've got some significant variation. And it's interesting, this is a slide that just is really to show you the variation in a complication rate that happens to, and it's a very serious complication that happens to some cancer patients. And in just putting up this slide, you can see the variation points going from about 2% to over 20% complication rate for this cancer tumour group for these patients. And each complication, to put it in financial terms, costs about £7,500. But when I put up this slide, and you can see I've not named the cancer tumour group, it's because I couldn't. I was told I can't publish this information in this environment and name that cancer tumour group. Why is that? If you were a patient, wouldn't you want to know who this hospital was and who this hospital is? I think there's a really big lesson for us in terms of the transparency of information and what can we do about that issue and how much help it can be to us in terms of spreading best practice. But what we do know is spreading best practice isn't unique to the NHS, isn't unique to the UK, and this issue has been around for a long time. There's many people in this room, I think, will remember this seminal report by the Institute of Medicine in America. It was published in 2001, and I've just pulled up three of their recommendations or observations. We have a system, this is back in 2001, unable to deliver today's science, not rocket science and technology, and it's going to get worse. It most certainly has got worse since 2001. We have a system that's designed for episodic care. I think that still is the case. And we have healthcare providers, hospitals like mine, that can work in silos, and that's absolutely still remains the case. I think it's also important, though, to remember that the healthcare industry or system doesn't face, this issue is not new to our own industry. So this is back in the 1880s, I think, where the Western Union Telegraph Company said that the telephone wasn't a great thing to have. They regarded it as a toy, one of the worst business blunders, I think, in history. But what's my point behind this? Why is it that the Western Union Telegraph Company said that? Were they run by stupid people? Don't think so. Very successful organisation at the time. Did they not understand what their customers would want? Well, I think they probably did. I think what this is about is that old adage that if you have a system that's designed the current state, it's very difficult to get that system to design something new. There's something called creative disruption. If any of you read any of the work by Clayton Christensen, who's a Harvard professor, has got some great work about healthcare innovation and how to get spread. He talks about the need for people and organisations to disrupt the current system. He believes that's the only way in which you will get spread of innovation. And I think that you can see example of that happening. So, why don't we learn? Why can't we spread learning? Well, maybe we just have to make it really, really obvious. I'm sure, we would learn pretty quickly, wouldn't we, if we read what was on this guy's back, if you can all see that, and we would follow him if he started running. But maybe the thing is all about just getting the benefits to our patients and families out there in a really, really good way. Maybe. I just can't get away from the fact that we have data like this. Now, this is mortality and the variation in mortality for the same cancer group, tumour group. Less than 4%, over 14%. Risk adjusted, take away all the usual excuses. The only explanation for that variation is differences in practice between the surgical teams, or the cancer teams. Why isn't this good enough to get people to change? Why isn't that unit learning from this unit? Or why isn't that unit being closed down for what they're doing? I look at this information and it comes in, and you see it in reports, you see it in task force reports, and it makes me cringe. It really upsets me because I think, why isn't the world changing? What is it that we have to do to make sure that our patients and families can get the best of care that we know that can be delivered within today's system with today's resources now? Well, to be fair, the system is really complicated. That's just to try to represent our complicated system. We know we have many points of entry. Our patients and families have to go through many different things. This is actually quite an interesting slide because it's an animated slide normally, and you can follow the patient around the system, but didn't have time to do that. It's so complicated, isn't it? And achieving change, getting one cancer unit to copy the practice of another one, that you can imagine the discussions that are going to happen about facilities, about the interdependencies with community services and radiology services, so on and so forth. The lack of money that unit might perceive it has in terms of its ability to deliver great care. And the world is complicated, there's no doubt about it. But that's where education, innovation and leadership comes in place. We can help people navigate through this complicated system. We can disrupt this complicated system. I'm not sure if you can read that. Another complication, of course, is that we are living in unprecedented times. The environment that we work in is radically changing from that industrial age medicine, where we've got tertiary, secondary, and primary care type of pyramid, to what's the primacy now, which is individual self-care, living in an information age. And it is complicated, isn't it? We've got complicated systems, we've got unprecedented change happening, technology driving expectations. But surely this is the right time. It's not the worst time to achieve innovation and spread. It's the best of times. There are conditions now that we should be leveraging to make sure that we can deliver the best of care right across all our units, all our hospitals, GP practices and community services. So let's just look at what that means. I've got two slides here about how, in my particular unit, we've achieved some change. And the first one's on falls. And what that shows is that we've managed to reduce falls. I think as long as I've been in the health service, probably every 2 years or so, I've been involved in a falls reduction project. And we've seen sort of little change, and then it drops down and goes back up again. And then we forget about it for a bit, and then all of a sudden there's another scandal, or we realise, well, we need to do something about it. We set up another project group, we do some more change, perhaps not learning the lessons that happened before, and so on and so forth. But why I've put this slide up, and it runs from September 2010 to July of this year, so it's not a great length of time, is I believe we've achieved a sustainable change. And we've achieved a sustainable change for only one reason, And that's the very different approach that we took to motivating and educating our staff to do what was right around falls. And it came to us from a ward sister. There was a ward sister in a cardiac surgical ward. Cardiac surgical patients could have a higher tendency to fall, apparently, because they can be more confused. And what she started to do was, for her more confused patients, she used to break the visiting time rules that we had in the hospital. And she allowed the wife or their husband or a member of the family to stay with that confused patient. And we noticed that in that ward, she had very, very few falls. So we'd done all the risk assessments, appropriate management of drugs and whatever for patients, but those patients were still falling. But she allowed a family member to stay with the patient and help the teams manage that patient. And you saw a dramatic reduction in falls. And we took that lesson and we spread it in the hospital. We got patients and their families to talk to our staff about what they'd experienced, the observations of care that they'd seen, and we spread the message to the hospital. And we now incorporate patients and families in the care planning of patients at risk. And has it changed practice? For sure, absolutely changed practice. And so going back to that industrial age, information age slide, well, we think we're harnessing the information age to provide patients and families with what can happen, what should they expect. Is a fall a unavoidable consequence of being in hospital? Well, it's not. We managed to achieve, we believe, a sustainable change that's really motivated our clinical teams. Again, it's not rocket science, is it? I'm sure there's hospitals who use a similar sort of approach, but why aren't we using that approach day in, day out, right across the NHS? And this is work across in some ways it's easier to organise within a hospital. This is work across different organisations. It's about 40 GP practices, community services, and 3 hospitals. And over a year ago, we established something called the Knowsley Community Cardiovascular Service. Cardiovascular disease in Knowsley, which is about a population of about 200,000, was really prevalent, and outcomes for patients was really poor, and it was costing a lot of money to deliver that care. And where we are a year later is that we've really reduced A&E admissions as a result of cardiovascular disease. Cardiac rehab, really important secondary prevention for improving people's lifestyles and longevity into the future is really improved. Patients are really happy compared to what they were previously. We've seen a lot of money come out of the system in terms of saving, and staff motivation and satisfaction has dramatically improved about this service. And what changed? What really drove this service was the fact that we were able to spread innovation from one unit, whether that was in the hospital, in GPs, or in the community services, and spread it through the district. And we did that for 2 reasons. One, because we had a brave PCT who constructed a contract that wasn't based on activity, it was based on outcomes. We had a brave set of hospitals who signed up to that contract, which is in essence a bulk purchase contract, which is always a bit difficult. And then we had teams of people who operated without their ID badges on. So you couldn't tell whether they were from Liverpool Heart and Chest Hospital, the community service, GP practice. And the energy that they displayed in working towards the ambitions of this service was tremendous. The spread of great practice that happened, and we expected a 3-year timescale around achieving some of these benefits. It happened so quickly because of the uniform purpose that they were working for. We stripped away organisational boundaries that could create problems to spread, and they were open and willing to change. We haven't put any new practices in. There's no fantastic new technology gone in here yet, although that's what they now want to do in terms of moving into new forms of telemedicine and others. It was just getting the best of practice that's been delivered today in pockets and spreading it. Now, there's 200,000 people in Knowsley who have now got a really, really improved service at less cost. I think it's a great example of how you can spread innovation. So in conclusion, some of us feel it's the worst of times. Well, sometimes it feels that way. But the times that we're in are times of unprecedented change, and those of you who are brave enough can take advantage of that to drive forward the innovations that you believe and you know are necessary to deliver care that we need to deliver. Because there still remains a huge chasm between what we know we can deliver to patients and what's actually delivered to our patients. We know that patients and families are going to be a really important ingredient in achieving that spread through transparency and information. And we know those patients and families are going to become true partners in the delivery of their care, because that's unstoppable. That we will not allow, patients and families will not allow that not to happen. And really, really importantly, it's our job, through education, through leadership, through the spread of innovation, to make sure that we encourage our people and systems to make the best of the opportunities that are provided to us here today in these times. Thank you.